Welcome to this explainer. Imagine waking up one day and literally no longer being able to trust your own senses. Today, we're jumping right into a highly structured, step-by-step clinical playbook for diagnosing and managing schizophrenia. We're going to see exactly how clinicians navigate from recognizing complex, fragmented symptoms to actually executing a life-saving treatment plan.
Here's our agenda for today. We'll be moving logically from defining the spectrum to recognizing symptoms, step-by-step diagnosis, differential diagnosis, treatment strategies, and finally, causes and prognosis.
All right, Section 1, Defining the Spectrum. Let's lay down the foundational definition of what we're actually dealing with here.
So the absolute nucleus of this illness is psychosis. At its core, we're talking about a profound impairment in reality testing. This means the brain essentially loses its ability to distinguish between what's real and what's just happening internally. You'll see abnormalities like hallucinations and disorganized thinking orbiting around the center of gravity, but without that fundamental break from reality, you're just not looking at the schizophrenia spectrum.
To put the sheer scale of this into perspective, the prevalence is 5 to 10 per 1,000 individuals. It typically strikes right in a person's 20s, completely disrupting the prime of young adulthood, though women actually often see a second peak later on in their 40s. And interestingly, the illness tends to present slightly less severely in females, with a male-to-female ratio of 1.4 to 1.
Moving on to Section 2, Recognizing Symptoms. Let's talk about what this actually looks like in the exam room.
Clinicians generally categorize the presentation into two main buckets. First, you've got positive symptoms. Now, positive here doesn't mean good, it means the tragic presence of abnormal behaviors. We're talking severe persecutory delusions, or what Kurt Schneider famously termed first-rank symptoms, like hearing voices commenting on your every action. On the flip side, we have negative symptoms, which represent the absence of normal behaviors. You'll see things like alagia, which is a decrease in spontaneous speech, avolition, a total lack of motivation, or affective flattening, where emotional expression just completely vanishes.
Now, beyond the cognitive shifts, clinicians are constantly looking for severe behavioral disorganization. And a fascinating, absolutely critical subset of this is catatonia. To get this diagnosis, a patient has to exhibit at least 3 specific physical signs. It could be waxy flexibility, where a patient's limbs can be molded into a position that they'll just rigidly hold. Or it could be mutism, or even echolalia, which is the involuntary mimicking of someone else's speech.
Okay, Section 3, Step-by-step diagnosis. How does clinical observation actually turn into an official DSM-5 diagnosis?
Well, this 3-step criteria is the ultimate diagnostic threshold. First up, the patient needs to have 2 or more core symptoms present for at least 1 month. Second, and this is a strict rule, one of those symptoms absolutely must be delusions, hallucinations, or disorganized speech. And finally, continuous signs of the disturbance have to persist for at least 6 months. This 6-month window is huge. It often captures the full course of the illness, like a prodromal phase of mild social withdrawal before the acute break, or a residual phase of cognitive decline afterward.
Which brings us to Section 4, Differential diagnosis. Because what happens when the symptoms look exactly like schizophrenia, but the timelines just don't line up?
Time is literally our best diagnostic anchor in psychiatry. Duration alone separates these major diagnoses. Check this out. If the psychotic episode lasts less than a month and the patient goes back to their baseline, that's brief psychotic disorder. If it lasts between 1 and 6 months, it's schizophreniform disorder, which actually has a fairly rapid onset. It's only when those continuous signs cross that strict 6-month mark that it officially becomes schizophrenia.
We also have to be super careful to rule out schizoaffective disorder. This one is tricky. It's a complex presentation that blends psychosis with distinct manic or depressive mood episodes. So, what's the vital differentiator? The patient must experience at least 2 weeks of delusions or hallucinations completely in the absence of those mood symptoms. That's the key.
Let's pivot to Section 5, Treatment Strategies. Once the diagnosis is locked in, how do we manage it?
Well, the very first therapeutic decision is the setting. Compulsory hospitalization is indicated right away for acute safety concerns, like if there's suicidal or homicidal ideation. It's also necessary when the patient is exhibiting profoundly disorganized behavior, like severe agitation, or honestly, when a highly controlled environment is needed just to safely establish the diagnosis in the first place.
For an acute episode, we really have to weigh our pharmacological options carefully. You've got first-generation typical antipsychotics, like haloperidol. They're highly effective, sure, but they carry a huge risk of extrapyramidal side effects, meaning really tough involuntary motor and movement issues. So today, we generally lean towards second-generation atypical antipsychotics. But it's a trade-off, right? Because these require super careful monitoring for serious metabolic risks, like sudden weight gain, diabetes, and hypertension.
And notice how side effect management is so predictably linked to time. Acute dystonia, which is a severe, painful muscle spasm, can hit within hours of giving the meds. Parkinsonism-like tremors tend to develop over days, and tardive dyskinesia, which involves those involuntary repetitive body movements, well, that can manifest after months of use. Plus, clinicians always have to be on high alert for neuroleptic malignant syndrome, which is an absolute life-threatening emergency.
Finally, Section 6, Causes and Prognosis. Let's zoom out and look at long-term outcomes and where this illness actually comes from.
It is endlessly fascinating how specific clinical features completely shift a patient's prognosis. Surprisingly, an acute, sudden presentation, especially if mood symptoms are present, actually predicts a much better outcome. We often see this in the paranoid subtype, which tends to preserve the underlying personality pretty well. On the flip side, a young, single male with a slow, insidious onset and predominant negative symptoms, that's a much tougher prognosis, aligning more with the hebephrenic or disorganized subtype.
And these clinical factors lead to wildly varied outcomes. It's definitely encouraging that 20% of patients experience a full recovery, but another 30% will relapse with periods of no symptoms in between. And tragically, the data shows a 10% suicide rate, which just reinforces exactly why early management and those acute safety protocols we talked about are so absolutely vital.
Now, looking backward at etiology, genetics play a massive, undeniable role here. This is highlighted by a staggering 48% risk of developing the illness if a monozygotic identical twin has it. That number is huge. It tells us that the underlying biological vulnerability is just incredibly profound.
But it's never purely genetics. Environmental factors always serve as the trigger. Things like an urban birth, maternal malnutrition, and cannabis use all play a part. But deeply complex family dynamics are intertwined here too. For instance, being raised in what's called a high emotional expression family, one characterized by hostility, severe conflict, or over-involvement, can serve as a powerful environmental stressor that actually triggers a biological relapse.
Which leaves us with a really provocative question to end on. How exactly do dormant biological vulnerabilities so perfectly collide with environmental stress to shatter human reality testing in such a specific, systematic way? It's a puzzle that continues to drive the very frontier of psychiatric research. Thank you so much for joining me on this deep dive into the clinical playbook.